Hello, everyone, and welcome to today's Conversation Series program, where we'll welcome members of the team at Duke to share their approach to donor selection for heart perfusion and devices. My name is Deanna Fenton, and I have the pleasure of serving as a Senior Manager of Program Development and Operations here at the Alliance. Now, first and foremost, for anyone interested in continuing education credits, please note that today's program will offer the following credits. Following the conclusion of today's presentation, you'll each have an opportunity to complete the post-event evaluation and select your desired certificates. Now, without further ado, I'd like to go ahead and begin the program by facilitating a few introductions, starting with our moderator, Sarah Castellanova, who serves as a clinical research coordinator and senior team lead at Duke University Medical Center. Joining Sarah is also our esteemed panel. Dr. DeVore is a cardiologist and associate professor of medicine in the Department of Medicine, Division of Cardiology at Duke University School of Medicine. His clinical interests include caring for patients and families with heart failure, including those with left ventricular assist devices and heart transplants. He is involved in and leads multiple large studies of patients with heart failure at both Duke University Medical Center and the Duke Clinical Research Institute. He currently serves as the medical director of the Duke Heart Transplant Program. Dr. Chet Patel is a heart failure and transplant cardiologist and associate professor of medicine at Duke University Medical Center. Dr. Patel has led teams to develop innovative solutions for patients with advanced heart failure and expanded access to heart transplant and mechanical circulatory support devices. These Duke programs are now amongst the largest in the world and provide multidisciplinary care while simultaneously training the next generation of academic clinicians, as well as maintaining a high level of scholarly output. Dr. Patel currently serves as the Vice Chair for Clinical Affairs in the Department of Medicine, focusing on care delivery across the medical specialties. And last, but certainly not least, is Dr. Schroeder, who is the Assistant Professor of Surgery in the Department of Surgery, Division of Cardiothoracic Surgery at Duke University Medical Center. He is the surgical director of their heart transplantation program and the co-director of their cardiothoracic surgery intensive care unit. He is the principal site investigator for the Transmedics sponsored clinical trial to evaluate the safety and effectiveness of the portable organ care system heart for resuscitation, preservation, and assessment of hearts from donor after circulatory death, where the first transplant program in the U.S. to utilize the Transmedics organ care system to perform a DCD heart transplant in 2019. So with that, I want to thank our panel for joining us today, and I'll go ahead and turn it over to Dr. Patel to get us started.
I'm going to get us started on the presentation, and then hand off to Dr. Schroeder. Sarah, I'm going to ask you to drive, I think. So if you go to the next slide, there are no disclosures for any of us to describe from this presentation. Next slide. So we're going to focus our conversation a little bit on heart preservation, and there's a lot of reasons to care about heart preservation when it comes to transplantation, but part of it is driven by the way that we allocate the hearts across the country, and many in this audience are pretty familiar with this schema that describes the sickness of the recipient and the potential to die without a life-saving organ. And that's overlapped with distance from the originating OPO. And rather than go into detail, it's easiest shown in these concentric circles, where the first organ offer is based on the severity of illness or the status of the patient. As you know, in heart transplantation, we do not have a scoring system, but it is mostly driven by the requirements to maintain circulation in the recipient. And then that's overlapped with concentric circles in terms of the distance. And so when it comes to preservation, this drives a lot of our behavior when it comes to organ acceptance, so that we get the best possible outcome for that recipient, depending on how sick they are. Next slide. And it matters more when we think about changing allocation schemes. And after the 2018 allocation changes in heart transplantation, what we've learned is that the mean distance to the organ and the total ischemic time both increased. And that had a lot to do with the removal of the local OPO privilege, if you would, for the surrounding centers, such that the first offer would actually go out to 500 nautical miles for the sickest recipients. What we've learned, and I have a slide showing our own experience in this, is that a thoughtful and perhaps better preservation approach reduces primary graft dysfunction, or PGD, and that translates into improved clinical outcomes both in the short term and longer term for the recipient. And better preservation not only decreases the incidence of PGD, but also expands our potential donor pool. So we can look at organs that could survive the transportation and preservation and perfusion process in transit to the recipient, and think about organs that would otherwise only be considered if they're within a short distance of our center as the recipient center, but then apply techniques to use that same organ at a distance. And when we think about higher risk donor hearts, we're talking about organs that have certain features, whether it be donor age, some amount of structural change, or even some coronary disease that would otherwise not tolerate ischemia very well. And as a result of that, thinking about preservation helps us, every center, think about the geographic reach that their center has. Next slide. In the overview of this slide, and the overview of this presentation, and through the slides, we'll talk a little bit about primary graft dysfunction as it relates to the pathophysiology of donor heart preservation, and then go through our options that we have been using here at Duke and some of our experience with that. Then we'll consider some outcomes data, and we'll conclude with cases. Next slide. So donor organ injury, this is true for many organs, but in the heart, after the beating heart is arrested, independent of the preservation technique, the organ undergoes the process of cellular damage through swelling. There's lactate accumulation due to hypoxemia, and that generates an inflammatory response, which, when reperfused, that organ can undergo significant damage in the time from explant and then during the implantation procedure. Those injuries are thought to be the major determinant of primary graft dysfunction, or PGD. And if you go to the next slide, we can talk a little bit about what that means. Graft dysfunction within 24 hours of heart transplantation, resulting in hemodynamic compromise through inadequate cardiac output. This has been codified or cataloged by the ISHLT into different severity levels, and depending on which side of the heart or ventricle is involved. The important things are that this dysfunction is typically transient, but in the time that it is ongoing, it can lead to very morbid conditions, such that comorbidities that the recipient enters into the transplant with become worse, and specifically renal failure and other end organ failure, as well as some more chronic dysfunction of the heart. Importantly, we recognize that it is not related to hyperacute rejection and not necessarily related to any pulmonary hypertension that the patient has come into the transplant with. Next slide. We've lived a little bit of this when we've talked about primary graft dysfunction. In my experience over the last decade, I've seen many programs go through a period of time where they start seeing primary graft dysfunction. We reviewed our data in terms of what happens to patients when they do experience PGD. And in the concluding statement, statement from this study that was led by our colleagues in cardiac anesthesia in 2018 was that there was both an increase in hospital mortality, a short-term mortality usually defined as 30 days, and an increased one-year mortality when the patient experienced primary graft dysfunction. So although transient, there seemed to be a persistent effect in certain cases. Next slide. We know of a few risk factors. We usually categorize those in terms of the donor, recipient, and the procedure itself. In terms of donor risk factors, we are always concerned about an undersized organ, the sex of the donor, and there is an increased risk factor of female to male transplantation when it comes to heart. That usually has to do with differences in cardiac output of the transplanted organ, and then donor age. If you click on the next slide, we'll move on to the recipient risk factors. Renal function is a risk factor for everything in every condition, but definitely comes out as another risk factor in primary graft dysfunction. The use of mechanical circulatory support devices, which are increasing in heart transplantation, diabetes, and the use of amiodarone, which is not uncommon as we see more and more patients presenting with ventricular arrhythmias that require heart transplantation. And then finally, if you go to the next slide, the procedural risk factors, and the major driver of that is truly ischemic time. Now, if you take all of these and you're part of a heart transplant program, you realize that there's only a few things that you can control in this. And if you click on the next slide, we've got a sense of what are the things that we can control. And if you keep clicking, Sarah, you'll see that there aren't many things that we can control as the donor and the recipient become available. However, until recently, we've sort of said, well, ischemic time is the ischemic time. It's where the organ comes from. But that is obviously changing, and that's why we've had a lot of interest in trying to modify that important procedural risk factor. Next slide. And because of that, we've also thought about how we can impact donor heart utilization. If we start modifying our ischemic times, we can actually increase the number of hearts that are being used by reducing the ischemic injury that occurs by using novel techniques and novel devices to transport organs. Here, we're just looking at the actual rates of donor heart utilization, and they remain quite low despite an increasing number of donor hearts being offered. Next slide. So back to this, we've talked about the procedural risk factor that can be modified. And as I hand off to Dr. Schroeder in the next few slides, this is where we'll talk about the techniques that are being used. Next slide. So as I move on and hand off, what are the options that Dr. Schroeder will be talking about? A lot of the data that we've collected up until recently has been in heart transplants done with traditional cold storage. But we will focus on our experience and the national experience using the Sherpa cardiac transport system and the Transmedics organ care system. And at this point, I'll hand off to Dr. Schroeder to talk about the details of each one of those systems and what our experience has been.
Thanks, Sarah and Chet. So our first option is the traditional static cold storage. And again, heart transplant was done this way for decades, and it worked pretty well. But those variables that Chet highlighted have changed. Recipients are older, donors are older. There are more comorbidities in both groups, and so again, this is the one thing that we do have control over. So when you think about cold static storage, the advantage is obviously it's super inexpensive, and it's easy to do. You recover the heart, and you put it in a bag, and then put that bag in a big bag of ice, and you put it in the cooler, and you get back on the plane. The big disadvantage is the lack of temperature control, and there's no ability to monitor or in any way change the status of the organ during transport. Next slide, please, Sarah. So cold storage attempts to produce a hypothermic arrest of myocardial cellular metabolism and to limit the myocardial energy usage. The issue with this is that there's definitely a time-dependent ischemic or hypoxic injury, and this is unavoidable. Prolonged cold storage is a risk of PGD, and we know that as Chet already said, and a risk of post-transplant mortality. If you look at that graph in the middle, and you look at the increasing cold ischemic times, the survival estimate goes down further and further. And just for reference, our average ischemic time here at Duke is about 3 hours, 35 minutes, 3 hours, 45 minutes. So somewhere in the middle. We've always known this, but we didn't have many options in terms of alternates in the past. Next slide. So, the issue with cold static storage is that there's protein denaturation resulting in diastolic dysfunction, which significantly increases below 2 degrees centigrade. The ISHLT in 2020 warned that freezing any part of the heart is undesirable. I always tell people it's sort of like if we put you in a bag of ice, you wouldn't like it either. And I'll tell you, as a transplant surgeon, it is not infrequent when we take the heart out of the bag of ice that there are regions of the heart that are frozen. Primarily, you're feeling the heart and it's the sort of epicardial fat. But if the epicardial fat is frozen, then you have to assume that the myocardium is too. In large animal models and in human studies, temperatures within this bag of ice can reach 1 degree Celsius within 75 minutes and 0 degrees in up to 6 hours. So again, we know this is actually has negative effects on the donor heart, but we didn't have a ton of options prior. Next slide. Enter the Paragonic Sherpa pack. So the Sherpa pack is essentially a super fancy cooler. Where you suspend, you see in the picture on the right, where you suspend the heart in the preservation solution. And then it is packed in this cooler, and they use special sort of ice packing that the system is designed to maintain a sort of constant temperature between 4 and 8 degrees Celsius. And again, we would think that this would be much more useful. I'll tell you again, qualitatively, that taking the heart out of the Sherpa pack, the heart feels exactly like when you put it in. And I've always said that seemed like a really good idea. Next slide. So again, there's the temperature control within a set sort of range. It's pretty easy to use and does not require any additional members traveling. The disadvantages are the cost, which is obviously greater than a reusable igloo chest and some bags and some sterile ice. And you do not really have the ability to monitor the organ function or metabolics while it's on the Sherpa pack. Next slide. What I will say is that if we gave this talk after April 28th, it'd be a completely different talk, because at ISHLT, there's going to be a tremendous amount of additional data from the Guardian Registry and studies, multi-center studies. But the Guardian Heart Registry is an international multi-center registry, and it's assessing post-heart transplant outcomes, comparing the Sherpa pack and traditional cold storage. Next slide. In this version of the data, they looked at 569 adult patients, and there were 255 on ice and 314 using the Sherpa pack. The baseline characteristics were clinically similar, except for those associated with the allocation change. Fewer patients in the ice cohort were transplanted in the post-allocation change. Likely associated with this change, the Sherpa pack cohort had 25 minutes longer ischemic time, fewer preoperative durable LVADs, and more preoperative temporary balloon pumps. Again, these are really changes that occur from the allocation change, and this is a registry, and so you can't really control for that. But if you look in the red box, the distance to the organ within miles was 264 miles using the ice, and 463 miles, and the ischemic time similarly was longer in the Sherpa pack group, 193 versus 217. Again, those were statistically significantly different. Next slide. And then the most importantly, so this is all what we're talking about, what we all fear is severe primary graft dysfunction. If you compare the control arm, the standard cold static storage of 10% basically versus 5%. So a 44% reduction unadjusted in severe PGD despite a longer ischemic time. Next slide. And this is just a Kaplan-Meier survival analysis showing these same results. The red line is the Sherpa group. The blue line is the standard cold static storage group. So again, from this registry data showing longer ischemic time, less PGD, and greater survival. Next slide. So then within this registry, they propensity matched the US outcomes. And, basically, again, a very significant reduction in severe PGD and a significantly increased survival, 88% versus 96%. So 38% reduction in all post-transplant mechanical circulatory support, 66% reduction in balloon pumps post-transplant, 60% reduction in newly placed ECMO or temporary VAD, 71% reduction in severe PGD, and then an 8.7 increase in 1-year survival, which is significant. Next slide. The next option is the Transmedics organ care system, and Sarah may have more numbers, but we got involved in 2016 in the EXPAND trial, which I will discuss, because we knew that this was the wave of the future, and not only for extended criteria donors, whether it be older donors or donors further away, but also DCD, which we're not going to spend much time talking about, but I think we've probably done close to 250 cases, and Sarah can correct me. Next slide. So the organ care system is basically a miniaturized cardiopulmonary bypass pump. And so when after the heart is recovered, you attach it to the pump, and we have a little movie, and basically it perfuses the heart with donor blood and a perfusate with a number of additives with oxygenated blood. It has a reservoir. You can actually change medications and flows and a lot of things on the pump, but it really is just a cardiopulmonary bypass machine that's been miniaturized and made portable, and allows for perfusion of the heart so that it can return to the recipient OR or with the heart essentially normothermic and beating. Next slide. The advantage is obviously there's minimal cold ischemic time. Essentially, no matter where you go around the country, the ischemic time is essentially 90 minutes. So you perfuse the donor heart with cardioplegia solution. It takes about 25 minutes or so to get it onto the Transmedics OCS machine. You transport it for as long as you need, and then you rearrest the heart on the OCS and then implant it, which say takes 45 to 60 minutes, depending on how you do it. So essentially 90 minutes. And so that could be from Raleigh, which is a 30-minute drive basically, or Puerto Rico or Wyoming, both places that we've been with the OCS. There are multiple methods of both direct visual and then indirect assessment of the organ function en route. The disadvantages obviously are the cost, and then you obviously need a larger team to go procure the heart. The cost is something that's quite interesting. I think what we have shown at Duke is that our wait time is shorter, our ICU stay is shorter, our length of stay, I believe, is shorter, and those are all cost-saving measures. And if you think about a patient, their cost of being in the ICU a day, it's got to be $5,000, honestly, if not more. And then what is the cost of primary graft dysfunction? And we've sort of looked at this, we haven't published it, but it's hundreds of thousands of dollars. And so I think, we're working on this financial data here, but I think that actually using alternate perfusion methods, although it costs more for the transplant episode, theoretically, it actually is a cost-saving measure. Next slide. So again, there are things that we can do on Transmedics to monitor the health of the heart. One of the things that is recommended is measuring lactates, and you see a graph of this of patients who donor hearts that were accepted and donor hearts that were abandoned on the pump. What I'll say about the lactates is that we need to do a lot more work to understand more what we should actually be looking at. We can do catheterizations on the OCS. It's not super easy, but we have had donors that were maybe older donors at higher risk for coronary disease, and we've done it here in other centers where you actually take the OCS to the cath lab and you set it up on something. We use step stools, and then you can actually inject into one of the ports in the machine and actually see the coronaries. It's not an ideal catheterization, but it does give you a sense for the large vessels and whether there are significant stenoses. Next slide. So there have been a few trials of the Transmedics OCS. The first one was Proceed, or the first one I'll talk about is Proceed 2. This is an open label, multi-center randomized non-inferiority trial assigning 1-to-1 recipients to receive either Transmedics OCS or traditional cold storage. And these were normal donors. Next slide. And so the recipients and the donors were essentially the same. Next slide. And then as you look, no matter how you looked at the data, essentially the results were equivalent, saying that this was a safe method of procurement or organ recovery. And so, essentially, if you look at all the primary and secondary endpoints, they were equivalent. And so this was helpful, but not as helpful as we wanted, frankly, because we weren't going to use the Transmedics to go to, again, Raleigh or Chapel Hill. We wanted to go again to Puerto Rico, and we wanted to use it for the 45-year-old donor with a little bit of coronary disease who was in, say, Miami. Next slide. So in 2016, the EXPAND trial started. This was a multi-center single-arm trial. And I can remember sitting in Nice in 2015 in a really hot, small room trying to design a control arm for this. And we really couldn't. There were probably 20 cardiologists and cardiac surgeons. And after about 5 minutes, I just stopped talking because I realized we were never going to come to any consensus. And frankly, this is a trial of extended criteria donors, and I'll get to that a little bit. And so there really, at that time especially, there was really no one who was willing or had equipoise to actually randomize patients to using the OCS versus standard cold storage. So, this trial was designed to evaluate the effectiveness of the OCS in extended criteria donors. And we'll next slide, we'll get to what that actually meant. So for this trial, to be eligible to use the OCS for the donor, either the total ischemic time had to be greater than 4 hours, or it had to be between 2 hours, more than 2 hours plus one of the additional risk factors. So older age with no cath data, a long downtime, left ventricular hypertrophy, reduced EF, and then a coronary angiogram with luminal irregularities, but no significant flow limiting stenoses, and then a couple other things. Next slide. And so, you look at this, and interestingly, people will criticize this study, which is hopefully going to be published soon, that these were not really truly extended criteria donors. And I have a ton of slides on this, but we didn't include a bunch. But the one thing that tells you that these are not normal donors is that the average number of refusals for these donors was 60. And you compare that to, in the United States, the average number of refusals for standard heart transplants is, I think, 2 or 3. So the third person on the list takes a normal donor, and in this trial it was 61. Of the hearts that were in the trial, 54% had one inclusion criterion, and 46 had greater than 2. Next slide. The trial met its primary effectiveness endpoints, which was both a composite of survival and freedom from severe PGD. Next slide. And this is an important slide. So the FDA, when looking at this data, really wasn't super psyched about us not having a control arm. So what we ended up doing in the trial was going back and looking at all the other transplants that were done at the centers enrolling patients in the trial. And so that was 1,800 transplants during this period of time, and compared the two results. And if you see that the results are essentially equivalent. And again, these are not normal hearts, and you're comparing them to normal hearts. And I think this is excellent data to show that the OCS can be used for not only hearts in a normal heart in Puerto Rico, but the 44-year-old who maybe was an alcoholic and had some coronary disease and some LVH, and also maybe liked cocaine too much. And I'll tell you, that is one of the patients we enrolled in that trial, and that recipient is still alive. And that is a heart that prior to this, no center in the country would have ever considered using. So next slide. And that's it. I'm going to turn it over to Adam DeVore. Hopefully we're generating some good questions.
Yeah, no, Jacob, that was great. And I think a good review of like why this matters. And then, what are the data to support this? So Sarah, I'm going to have you, just kind of a summary here, like what are the things we care about? Donor risk of PGD, recipient risk of PGD, ischemic time, explant complexity, which I think we'll get back to during our discussion, and then kind of the procurement team expertise. And then Jacob alluded to cost a couple of times during his comments, but I put together just a couple of case scenarios. I meant for them to be brief. You can go to the next slide. And what I was hoping to do is just try to put you two on the spot to think a little bit about what are some of the things that we are often talking about. Usually it's in the middle of the night, but now it's nice. It's like 4:30 in the afternoon. We can do this and talk about like what preservation and procurement approach should we use for this next transplant. And just an idea to try to like, what are some of the factors, what things really drive these decisions? And I'm hoping this will lead into a good Q&A session here in just a few minutes. But so the first one has a bit of long cold ischemic time. So I'm happy to provide other examples here, or other data points. 28-year-old donor who died of an overdose and had 35 minutes of CPR, but the heart looks normal now. And then, because of distance, the expected cross clamp time is kind of 4 to 5 hours, and our recipient's low risk for PGD. So when I look at this, I think like, wow, that's a young donor. Yes, there was CPR, but the heart looks great. For those of us that work with Jacob a lot of times when we tell him the young age, he that's all he needs to hear. He's ready to go. 28, that's good enough. But this heart looks great, but it is going to be 4 to 5 hours of travel time. And there was CPR. So what, maybe Jacob, I'll put you on the spot first, but like, what would you think here in terms of if we were going to do this transplant tonight? What would you be thinking of, whether your options here would probably be a Sherpa pack or OCS?
Yeah, so I think those are your two options. As you know, my version of baseball, you get 5 strikes, not 3. And so, 35 minutes CPR, that's a lot of CPR. That's 1 strike. And then the ischemic time of 4 to 5 hours, that's long. And frankly, a low risk patient. So that's 2 strikes. The 28-year-old obviously is really is a major bonus. And you're absolutely right. I mean, I think the two most important things in my mind are both the donor age and the ischemic time. And so, the 4 to 5 hours, I think, honestly, again, there's going to be a lot more data on Sherpa pack coming out of ISHLT, and that's going to support its use. I think I honestly would still probably use Transmedics for this. If you're saying 4 to 5, if you're saying 3.5 to 4, then maybe I would consider Sherpa pack. I don't know what you think.
Yeah, I think this one's on the fence. I think we would consider some other things in terms of if we were doing simultaneous transplants and things like that, I think that would play a role in this in terms of our decision making. But I think we could go either way on this one. And I think we would the one thing that's out is just sort of traditional static storage, and I think that's the important thing. Where this in an era of static storage, the 4 to 5 hours up front would have scared us, despite the 28-year-old donor. And so I think a low risk recipient is very important here.
I think the one other thing that I always tell people from other transplant centers too is you have to create your own wins to be successful at this. And I think a lot of centers would say, oh, it's a young donor, but it has some risk factors, and well, okay, so we're not going to turn it down because it's too far away. And oh, they had some CPR. And we wouldn't do that. We would create a win out of it using this heart successfully. And honestly, I think we probably could use either method, either Sherpa pack or Transmedics.
Yeah, that's what I was thinking when I was putting it together, was that, this, depending on those other factors Chet was talking about, a lot of it's like how much, who else is left to deploy from the team, who else could go. So, I think different things, and you could just move these numbers a little bit, 20 minutes of CPR or 4 hours or 3.5 to 4, like Jacob was saying. I think you get slightly different answers, but this is definitely the gray area. And if you wanted like, a study I'd like to see, I think it's these types of hearts where you might compare OCS to Sherpa. I don't know if we're actually going to ever see that study, but I think that's an area where it'd be great to get more data, non-registry, but actually randomized data.
Yeah, I think the important thing is there, I think you're right, Adam, that, and Jacob, you mentioned this too, is that, it's 3.5 to 4 versus 4 to 5. We've never been surprised by shorter ischemic time. So I think we can always make sure it's going to go on the other end of it. So, like, well, that got here fast. That's never been sort of our experience. I think you can always add a little time on the back end of it. So that makes a difference.
Use the fast plane for this one.
Yeah. Yeah.
Well, that's the funny thing too. I mean, the newer studies are talking about not just ischemic time, but looking at distance from the transplant center, right? And that, frankly, having done this for enough years, that doesn't make any sense either, because if we go to Washington, D.C., sometimes it's 45 plus minutes in the ambulance.
Yeah, that's right.
And so, I mean, there are just so many variables. And again, we have done a good job here of creating wins out of situations that could be disasters. By using these advanced technologies.
Creating wins. That would be a great title for the talk. It's good. I like that. Sarah, can you put up the next one? Thank you. All right. So recipient complexity. And again, we can move the variables here however we need to, but I'm thinking of a donor who's got low PGD risk, probably a heart that every center in the United States would accept. But the recipient's got some things. And so, complex congenital heart disease, I put in transposition with the mustard. It's going to be a difficult start to this case, and currently on ECMO support, very sick, and needs a transplant soon. How would you think about this one? Again, I was kind of thinking of, and I'm happy to add numbers around travel time here, but how do you think of what are the factors that would push you towards OCS and just pure recipient risk, which is not really what Expand tested?
Yeah, I mean, I just always tell the story that the first time we did a congenital transplant with, and we used OCS, so we actually delayed the cross clamp at the donor hospital, and so they got to work. The heart looked fine. I actually went on the recovery, and the heart looked fine, and then we delayed a little while, like an hour or so, and then we had at least an hour and a half travel. So that's like now 2.5, 3 hours. And I got back with the heart on OCS and it looked amazing, blah, blah. And 2 of the surgeons here spent 2.5 more hours taking things out of the donor, the recipient, like stents, and they were putting patches in. And that was about, it was about 5 hours of surgery. And, in my mind, I don't really think I don't really feel good about not using OCS for these cases, because you sometimes just never know what you're going to find. And again, it costs money, but the risk of PGD in these patients, if things don't go well in the OR, is significantly high. It is, and it can be obviously catastrophic for the recipient and their family. And so, in my mind, using this for these complex congenital cases, and maybe the more complex LVAD explants, is a very, very smart thing to do, honestly.
Yeah, I think I'll add to that a lot of the trial data that Jacob presented today and has presented before is really focused on the donor and the travel time and the ischemic time as sort of entry criteria, but the recipient complexity has never really been studied, but I don't think has to be, because those two, the time that reducing these, allowing the heart to perfuse and remain healthy, allows so much more time for our surgical colleagues to do what they need to do, avoid all the booby traps, as we like to call them, from the congenital procedures. And then another point on cost, one of the things that we learned around PGD was that a big driver of cost was blood product use, and the amount of care and time that can be taken by Jacob and others to reduce the bleeding risk, and then not expose that new heart to all that blood that needs to go in after is really helpful for a patient for a recipient with high complexity, whether that be a VAD explant or a congenital heart disease where reconstruction is required.
Great. I've got one more, Sarah. So donor PGD risk. So thinking about an older donor, and I might ask you just to talk a little bit about how we think about these hearts, how we started thinking about it during expand and now. So 48-year-old donor had trauma, but did receive CPR 30 minutes. Initial EF was low, but then recovered. Coronaries have some mild CAD, but nothing prohibitive. And you're looking at 2.5 hours for an older recipient with CABG. So this would fit in within expand. So I guess what I was going with this is, like, do all these need OCS? Are there any Sherpa cases that you would use for an expand-like donor?
I think maybe you're trying to bait us into saying
no right answer.
No, this is a good one. But
we go back and forth.
No, this is a good one, because this is, if before we were using OCS or even Sherpa Pack, we'd say, well, would you use this heart if it was in Raleigh? For those of you on the call that sort of know the geography of this area, Duke is in Durham, which is about a 25-minute, 30-minute drive to Raleigh, which is the capital of North Carolina, and that's become our sort of benchmark to say, well, if we take it close to home, if we could replicate that, then with OCS, then would you consider taking this heart? And if the answer to that was yes, then we'd probably take it. I think the key comment here that Adam was put in there is an older recipient, and I think it's very fair, because that older recipient, perhaps who's lower on the list, has a few more chances to get a good offer, or an offer that we could use, and they become less of a good recipient when they come to a higher status, as their risk of complications becomes markedly increased. So I think this is a case that we would look at this heart very carefully and likely use OCS to help recover the heart. Jacob, I don't know if you think about it differently.
No, I agree. I can count 6 strikes in there.
It's a Jacob baseball. Don't forget that. That's an important pearl of. I remember the first time I was like, "What sport is he talking about?" I don't know what he's talking about.
But, again, they're just. But again, you could subtract a number of those risk factors. But I think Chet is absolutely right that the recipient here is probably the most important. So an older donor with a reoperation. And so again, you have to minimize your risk of primary graft dysfunction, because that patient is going to do exceedingly poorly with primary graft dysfunction. Right. And so, I would use OCS. If you take out 1 or 2 of those strikes, then suddenly you're thinking, if it was just a 40-year-old donor, but was otherwise okay, then Sherpa Pack would be great for this recipient.
So are there patients that you enrolled in expand that you would now use a Sherpa Pack for?
Yes, most definitely. And the thing about extended criteria donors that we know from that Samsky paper is that we at Duke, we've been using extended criteria donors for 15 plus years, and their ischemic times weren't super long. And again, that's why we always thought, okay, if this heart was in Raleigh, we would use it, because that's what we did with extended criteria donors. And we know that those people don't live as long as standard sort of transplants, but they don't die from graft dysfunction. They die from renal failure and strokes and cancer and things like that. Yeah. And so, again, I think luckily the field has shifted in that direction too. I mean, I'm so pleased to see with the 48-year-old donor that we are 6th on the provisional yes, because that means people are using it. And frankly, I don't really care how they use it, what method they use, but people are using those donors and really expanding the donor. But there are a number. That's the critique of that study, is that some of those now although it was different in 2015, frankly.
Yep.
Even that short a time ago, that not many people were using those hearts, but now people are, honestly. And again, so I would use there are a couple of things within Expand that I would say we would just use Sherpa Pack for that.
Mm-hmm.
Great. Well, Sarah, those are the end of my cases, but I'm hoping people have questions here in the last.
Absolutely.
Yeah.
Yeah, wonderful talk, everyone. Thank you so much. I'm going to stop sharing. Creating Wins should have been the title. Definitely the spirit of what we do here at Duke, and then hopefully the spirit of the next wave of transplantation with all of these options. Let me looks like there's nothing in the chat. If any, a reminder to put some comments in the chat if you have questions for our presenters here today. Since there's nothing there currently, I do want to have you all talk a little bit about the implications of either Sherpa Pack and or Transmedics or any other options in the pediatric setting. Do you think that this holds weight in that arena? Do you think it's going to make a difference there now that we're able to use it now that it's commercial?
Yeah, what I will say is that, unfortunately, pediatric transplantation is the area where we have the most to gain, because there's so many children who die with heart failure on the list. I mean, their waitlist mortality is so much higher. So there's so much that we can gain by using these technologies. The Sherpa Pack actually is being used for some pediatric patients, and I think that's a great idea. I mean, you can't connect it the same way. You basically just put a stitch through the aorta and you hang it in there with that stitch, but it can be used. And again, the pediatric hearts, most of them will tolerate a longer ischemic time. So you think, well, okay, in the pediatric heart, if the data that's going to come out on ISHLT this year says, well, maybe 5 to 6 hours with Sherpa Pack is okay for a standard donor, well, then what is it with a pediatric donor? It could be significantly longer. And I can't, don't necessarily quote me on that, but I bet it will be. And the issue obviously with Transmedics is simply the size of connections, the size of the pump, and we don't know what to flow smaller pediatric hearts. But I know there are people here at Duke, Joe Turk and others who are very interested in making pump modifications.
Come on, baby.
And learning how to use the OCS for truly pediatric, neonatal and very small donors.
Thank you so much. Looks, Dr. Patel, did you have a comment as well?
No, I think outside of the technical aspects, I was just, the key issue here is the number of, as Jacob mentioned, the waitlist mortality for our pediatric patients is very high. And it's just the number of offers that they get are much smaller. So expanding the geographic reach, if we can make some headway in terms of the technical challenges, then it should lead to a situation where every potential recipient on the pediatric waitlist has a huge geographic reach in terms of the organ offers that they get. Should be able to get there to a long way across the country.
Thank you. It looks like someone named Chris Chan has their hand raised for a question.
What's up, guys? How you doing?
You can ask Jacob to explain Jacob baseball. So he's gonna...
Hey, Chris.
No, I've heard about Jacob baseball many times. We use it in our home. I'm one of the cardiologists at UNC, for those who don't know me, and friends of all these guys. My question is about, smaller centers, smaller volume centers have different approaches, and I think they've traditionally taken the approach of being very, very conservative with donor selection. How do you think these technologies should be applied to centers that are doing 10 to 20 transplants? Do you think the fiscal considerations and the approaches are similar? Do you think there needs to be different ways of kind of approaching it in smaller centers? That's my first question. And my second question is, when you have all these tools, do you think that there's indication creep that comes on with just wanting to use OCS for every case? And how are you kind of really, are you trying to stay true to data, true to kind of protocols? How are you making these decisions? Because, you guys make very compelling cases, and it seems like, boy, you'd want to use one of these technologies for every single case you possibly can, which again comes at a cost.
I'll take a part of that. I think I think your point about the smaller volume center and sort of the risks that they're willing to take, in particular donors, is an important point. I think what these technologies allow for, Chris, are to be able to gradually push the limits on what a center is comfortable with, right? And my recommendation would be to take one or two variables that that particular center has been wary of, and see how these technologies can impact that. And let me give you an example. You know, obviously we live in a very we're very fortunate because we've been, as Jacob mentioned, we've been talking about extended criteria donors for some time, and the technologies that we're talking about really did allow us to just do more of that. But if a center is reluctant about a donor above a certain age, by shifting that by 5 years or 10 years, depending on what that age is, and applying a technology for those type of donors, you could actually increase your donor pool significantly. And so I think those are the ways to sort of approach it, which is to go piecemeal, and look at where the comfort zones are and try and push on one or two of those comfort zones. I can let one of the other guys, maybe Adam, talk about indication creep. I think we've done a nice job of trying to be thoughtful about it, and we definitely had the question asked to us about whether we're going to use OCS for everything, and we quickly came to no. But Adam, maybe you want to talk about that a little bit of the financial analysis as well.
Yeah, we've thought a lot about that. We've alluded to cost a couple of different times, and I think that is an important variable. I mean, Jacob makes a compelling point that the cost of PGD, obviously it's a terrible risk for the patient, but the financial cost is also quite high. So the math is a little bit complicated when we're trying to figure these things out. I'll just say for us, we have sat down and looked at we look at this all the time of what donors are we saying yes to, what donors are we saying no to, and how are we doing this? And I honestly think it sways every once in a while. Like one of the things we were talking about recently is just as our DCD experience, I know it's a little bit out of what we're talking about, as our DCD experience has grown and grown, how can we start to expand the number of donors that we say yes to? And that just comes from sitting down and looking at this and trying to understand what areas are low for us. I think it's actually the same guiding principle that Chet was talking about. I'm trying to pick one area and work on it for a while. But I think you're right, Chris, though, that the possibility of indication creep is there. But I think every couple of months sitting down and looking at what's the experience been and trying to think a lot about all the different implications of the tools that we're using has got to be part of this. Jacob, anything else you'd add?
Yeah, I mean, I think other centers have the benefit of having people like us. So we were like in the car, like Thelma and Louise going off the cliff because we believed. But the data is out there. The DCD using Transmedics, that trial is going to be published very soon. The expand will be published hopefully soon. Ex-Situ is going to show a lot of data on the Sherpa pack. And so what you got to do is then find somebody who at your center who's willing to embrace that data and say, okay, well, we did 10 transplants last year. What would happen if we did 15 and used Transmedics for 2 of them? What I will say is we use Transmedics for 35% of our transplants, and we use Sherpa pack for the rest of them, frankly. I think the only time we use ICE is when it's an in-house donor.
Yep. And
again, I don't have the financial data in front of me, but no one has ever come and told us that we're losing money. They never once have said that. Despite this, basically, it's just okay. How many times do you think you're going to use Transmedics this year? We need to budget for that. Which I don't even know what that really means in the grand scheme of things. But I don't think that the financial cost, and again, if you're at a center that does 10 transplants or 20 transplants, one case of PGD probably can wipe out the direct contribution of every single other transplant,
right?
Easily.
Yeah, I think one of the, Chris, you made a good point about indication creep. I think it's bidirectional. A comment that Adam made and Jacob answered, so through this experience, we've figured out like, hey, you know what? We use Transmedics, we use OCS for that one, but we could have got away with just with cold static storage with Sherpa Pack. So as you go through this, you learn, but having the OCS gives you sometimes the confidence to look at donors that you wouldn't otherwise look at. And I think that's been an important thing for us to learn as we drove off that cliff. It was good to think about that.
It has been interesting that in the last 6 to 8 months, there have been a number of hearts that 2 years ago we would have used Transmedics for, and we're just like, oh, we'll use Sherpa, and it's worked. Yeah, and I think there are huge benefits to both these technologies, and I agree with Adam. I would love to see a trial of some slice of these donors where we could randomize to either, but I don't think that'll ever happen.
This is great. I mean, I think that there's, a lot of this has been very subjective for a long time with what is the right donor, what's too old or too sick, and I think what you guys have done and these registries and studies really kind of actually put some data and science behind it. So I think it's a really exciting time in heart transplantation and in donor selection. And I think it's, those are all really, really helpful tips and really helpful pieces of information. And, we're certainly looking at and starting all these programs up as well.
Well, thank you. No other questions are in the chat. So I'd love to just toss one final question to all of our presenters. The last several years, we've had Sherpa Pack and Transmedics come to market, which has changed the way we do things entirely. What do you hope for the next 5 or 10 years now that these devices are commercial and gloves are off? What do you hope to see for the transplant population here in the next 5-10 years? We can start with Dr. DeVore.
Yeah, I think Jacob alluded to this. I think understanding what's happening to the heart on the OCS is like the next thing that needs to happen now. The lactate is not the data that we need. And the reason I think it's so important is it allows you to start to push other frontiers, like taking a low EF heart and trying to recover it on the device, trying to otherwise manipulate the heart while it's on the device. And those things can't happen until we understand how a healthy heart is staying healthy. So I think that is, if I could sit down and read any pile of data, that's what I would want right now. So we can start pushing the envelope in other ways.
Yeah, I would agree. I would agree. What medicate, what pharmacologic, what biologic, what genetic agents can we administer? It is the ideal platform to do research because the blood just keeps going through the heart. You can't more effectively give something to a donor heart than this system. So we just need more smart people to think about this, and a lot of people are working on it. I think the other thing obviously is there are some cold perfusion devices that are out there, and the question will be how successful, how useful are they? I mean, we know from our colleagues in Australia who've been using one of the cold perfusion devices for their DCD transplants that they are very happy with it. So again, I think we just need to gain more experience and data here in the United States.
Yeah, I don't know much to add. I think the way that we get there to a consideration of a trial is by probably going by surrogate data at this point, which is what is temperature, how much does temperature matter, and how much does perfusion matter? And we may have an opportunity to dissect all of that out if we talk about cold perfusion as well. So you can imagine, smart people smarter than me looking at perfusate samples and samples from storage and understanding what the metabolome of the heart looks like as they are transported and perfused. So it'd be fascinating to know how we can modify based on what we learn in the solutions.
I agree completely. Thank you all so much for your time. This is wonderful. And there are no further questions here in the chat or any other hands raised. Let me just make sure. Yeah. And I will toss it back to you, Deanna.
Oh, so sorry about that. My computer was taking a minute to load there. But I just want to say on behalf of the Alliance team, thank you all so much. Sarah, thank you for doing a phenomenal job helping to facilitate today's discussion. And of course, thank you to our presenters for joining us today, taking time out of your very busy schedules. I know Dr. Schroeder may have just been leaving the OR or going to the OR, so I appreciate you all taking the time to be with us. For everybody else in attendance, we'll be sure to share the recording and the presentation handout with all of you. And with that, I wish you all a wonderful rest of your day. Take care,
Thanks, everyone. Great job, Sarah, as always.
Thank you.
Thank you all.
See y'all around.